suppose this is our blood vessel, okay, and via this blood vessel the blood is flowing, okay. Now suppose some injury has happened to this blood vessel, then what will happen? Because of this injury the blood will start coming out of this blood vessel, isn't it? Like what we did in what we used to do in our HAP lab, we will prick our finger, and after pricking the finger what will happen? Yes, the blood will start coming out, okay. Now after blood starts coming out, then what will happen? After sometimes the bleeding will stop, isn't it? And why the bleeding will stop? Because there will be formation of a aggregate of platelet, to which we call it as a platelet plug, okay. So because of this platelet plug formation the bleeding will be stopped, but for a temporary basis. Means if we'll apply pressure with more, we'll apply some kind of pressure, some kind of force, with more pressure the blood will start coming out, isn't it? So this platelet plug will provide a temporary way for stopping the bleeding. But after sometimes what happens, blood coagulation will be taking place, and because of blood coagulation what will happen? Yes, there will be a formation of fibrin thread, an insoluble fibrin thread, which will permanently stop this bleeding, okay. So in this manner the bleeding will be stopped. Now after sometimes what will happen? This blood vessel, the endothelium which was ruptured, it will repair itself, okay. And after getting repaired we don't want this platelet plug or this insoluble fibrin, this clot we do not want, isn't it? So this entire thing will be removed off, and this will be removed by a substance known as plasmin. Now if this thing is not removed, then what will happen? It will provide obstruction for the flow of blood, isn't it? So for this reason we need to remove this plug, okay. Now if there is any kind of disorder in this process, it will lead to a clinical consequence. Like if the platelets are not there, then the platelet plug formation will not take place, and the bleeding will be continuously happen, okay. This is one problem. If there is no platelet plug formation, the bleeding will not be stopped. Now second thing is, if suppose there is no coagulation taking place, then the bleeding can occur very easily. Now third thing is, if there is no plasmin available, if this clot, this platelet plug is not removed, then it will provide obstruction. There will be a problem known as thromboembolism. It will take place, okay. Now suppose if platelets are not available, then we will provide platelet. If fibrin formation is a problem, then this problem can also be solved by giving clotting factors. But suppose if this platelet plug and this fibrin, it has been not removed, then it will lead to thrombotic disorder such as myocardial infarction. So we have to give a drug to decrease this thrombus formation. So for this reason, first we need to understand the hemostatic process taking place in arteries and veins. Okay, we know we have got arteries and we have got veins. Arteries will carry oxygenated blood and veins will carry deoxygenated blood. And in arteries as well as in veins, such kind of problem of thrombosis will take place. Okay, so in red color I will be drawing artery. Suppose this is our artery, and this is our vein, okay. Now whenever there is a damage to the artery, then what will happen? Then first of all, lots and lots of platelets will be aggregated over here, too many platelets. Whereas in case of veins, the number of platelet is a bit less. And eventually after platelet plug formation, yes, what will happen? There will be formation of blood clot, or you can say fibrin. So in case of arteries, the fibrin are less, whereas in case of veins, a huge amount of fibrin thread will be formed. Okay, so this is the difference in the hemostatic mechanism of arteries and veins. In arteries, too many platelets will be there and fibrin will be less, and in case of veins, the platelets will be few but the fibrin thread formed are huge. Now if we want to remove the arterial thrombosis, as in case of myocardial infarction, when there is thrombus in the artery like coronary artery or cerebral artery, the more effective drug will be antiplatelet drugs, because here the platelets are more in number. So whenever we want to treat thrombotic problem in arteries, we need to give antiplatelet drugs. Okay, antiplatelet drugs. Like when if the problem is myocardial infarction, we can treat it with the help of antiplatelet drugs. But in case of veins, for venous thrombosis, like in case of deep vein thrombosis or pulmonary embolism, the more effective drug over here will be antifibrin drugs, because here fibrin, insoluble fibrin thread is more in number. So for treating thrombotic problem of veins, we need to give antifibrin drugs. Okay, antifibrin drugs. Now we'll discuss about these two drugs one by one. Okay, so we shall start our discussion with antiplatelet drugs. Okay, so since we are discussing about antiplatelet drugs, means we are discussing about how to solve the thrombotic problem taking place in arteries, because in arteries there will be huge amount of platelet blood formation. Okay, now suppose this is your artery, and in this artery blood is flowing continuously, and along with the blood all the blood cells will also be flowing, isn't it? We have got red blood cells, white blood cells, and platelets. Now since we are discussing about antiplatelet drugs, I'll be drawing platelet over here. So whenever a blood is flowing, along with that platelets are also flowing via these blood vessels. Now we know what is the property of this platelet. Yes, the property of this platelet is to aggregate, to stick to one another. But whenever the blood is flowing, the platelets are not sticking with one another. Why? Because the reason behind that is inside the platelet contains an important receptor. There is a glycoprotein known as GP2B 3A receptor, we can say, and this receptor is present inside the platelets. Okay, now suppose there is a damage to this blood vessel, and because of this damage, the damaged blood vessel will be releasing two important chemicals. First one is Thromboxane A2, and second chemical is adenosine diphosphate. Okay, now what these two chemicals will do, because of these two chemicals, because of under the influence of these two chemicals, it will cause exteriorization of this GP2B3A receptor. Okay, this GB2B3A receptor will get exteriorized, means it will be now present on the surface of the platelets. Means the receptor that was present inside this platelet will now become on the outer surface of the platelets, means they will be exposed, and because of exposure of this receptor, the platelets will become sticky and they will start to aggregate. Okay, so this is the reason why the platelets will get aggregated whenever there is any kind of injury. Now what is our motive? We want to stop this aggregation of the platelet. Now how can we stop this platelet aggregation? Yes, the very first option is better to inhibit this Thromboxane A2. Second option is to inhibit this adenosine diphosphate, and the third option is to inhibit this GP2B3A receptors. Okay, so we have got three options by which we can inhibit this platelet plug formation or platelet aggregation. Now which drug can be used for inhibiting this Thromboxane A2? Yes, we have got a very important drug known as aspirin. Okay, so aspirin is a drug by which Thromboxane A2 can be inhibited. Now what kind of drug can be used for inhibiting adenosine diphosphate? So adenosine diphosphate can be inhibited by two important drugs. They are clopidogrel and ticlopidine. Okay, so these two drugs can be used for inhibiting adenosine diphosphate. Now what kind of drug can be used for inhibiting this third option, for inhibiting GP2B3A receptor? So this receptor can be inhibited by a drug known as apiximab. Other drugs are tirofiban and iptifibatide. Okay, so these are the drugs that can be used as antiplatelet drugs. Okay, so the first drug is, these are thromboxane A2 inhibitors. The second class of drugs are adenosine diphosphate inhibitors, and the third class of drugs are GP2B3A receptor inhibitors. Okay, so we'll talk about these three kinds of drugs one by one. Now we shall start our discussion with thromboxane A2 inhibitors, that is aspirin. Now you know what is this thromboxane A2 actually? Yes, it is a prostaglandin, isn't it? And you know how the prostaglandin synthesis will be taking place? Yes, from the membrane phospholipids, isn't it? Now suppose this is a membrane phospholipid. On this membrane phospholipid, it is acted upon by the enzyme phospholipase A2, and it will convert phospholipid into arachidonic acid, isn't it? Now upon this arachidonic acid, it can either acted upon by cyclooxygenase enzyme or lipooxygenase enzyme. Whenever lipooxygenase enzyme acts on arachidonic acid, it will lead to formation of leukotrienes. But when cyclooxygenase enzyme, it acts on arachidonic acid, it leads to the formation of prostaglandins, isn't it? So the initial prostaglandins so form are PGG2 and PGH2. These are the parent prostaglandins, and they are highly unstable in nature, and they eventually get converted into different products in different places, in different areas. Like when they come to platelets, it will convert prostaglandins into thromboxane A2, because platelets contains the enzyme thromboxane A2 synthase. Okay, in the platelets, thromboxane A2 are being formed, and in the endothelium, PGI2 will be formed, prostacyclin 2, which we call, and it is written as PGI2. So in the endothelium, now the blood vessels contains endothelium, there PGI2 is formed, and in rest other areas, depending upon different enzyme, will get different products like PGD2 or PGE2, PGF2 alpha, and so on and so forth. Okay, now we are concerned about these two compounds, thromboxane A2 and PGI2. Now what is the nature of this thromboxane A2 and PGI2 is, thromboxane A2, it will cause platelet aggregation, isn't it? Thromboxane A2 causes aggregation of platelets, whereas PGI2, which is present in the endothelium, it will inhibit aggregation. Okay, so thromboxane A2 will induce aggregation, PGI2 will inhibit aggregation. Now what we are talking about, we are talking about the drug aspirin. Now what this aspirin will do, aspirin will inhibit this COX enzyme. Okay, it is an irreversible COX enzyme inhibitor. When this COX enzyme is inhibited, means there won't be formation of PGG2, there won't be thromboxane A2, and there won't be PGI2. Means nor aggregation, neither inhibition of aggregation will be taking place. Okay, but you know what happens, these platelets does not contains any nucleus, but the endothelium, they do contain the nucleus, and because that nucleus, they can synthesize new COX enzymes, and those COX enzyme can convert arachidonic acid into PGG2 and then into PGI2. That means after, for some limited time, the level of both thromboxane A2 and PGI2 will be reduced, but after some times, because these endothelium contains nucleus, they can synthesize new COX enzyme, and they can synthesize new PGI2, and the level of PGI2 will be increased. Now what this PGI2 will do, it will inhibit the aggregation of the platelets, and this was what we actually wanted. We want to inhibit the platelet aggregation. So aspirin are the drugs which can be used as a inhibitor of thromboxane A2. Okay, they will inhibit the platelet aggregation. So this is the first type of antiplatelet drugs, that is thromboxane A2 inhibitors. Another class of antiplatelet drugs are the drugs that will inhibit ADP, adenosine diphosphate, and we have got two drugs, clopidogrel and ticlopidine. So we will check out about these two drugs. Now, suppose this is a platelet, okay? Suppose this is a platelet, and on the surface of the platelet contains a very important receptor. The name of this receptor is P2Y12 receptor. Now what will happen whenever there is a damage to the blood vessel? There will be release of adenosine diphosphate, and this adenosine diphosphate, it can activate this receptor, it can activate this platelet whenever it binds to this P2Y12 receptor. So basically this is the receptor for adenosine diphosphate, and this receptor is present on the surface of the platelet. Now, suppose if we antagonize this receptor, if we inhibit this receptor, means the adenosine diphosphate, it cannot come and bind with this receptor. That means it cannot activate this receptor. Okay, so this is how we are inhibiting adenosine diphosphate. So we basically require antagonist of this P2Y12 receptor, and we have got two important antagonists, that is clopidogrel and ticlopidine. So basically the mechanism of action of this clopidogrel and ticlopidine is, it is an inhibitor. It will block this P2Y12 receptor which is present on the surface of the platelets, and thereby it can inhibit the activation of adenosine diphosphate to these platelets. Okay, so this is the simple mechanism of action of this clopidogrel and ticlopidine, that is by blocking this P2Y12 receptor. And once these receptors are been blocked, they will remain blocked for a long period of time. So that is why if we give this clopidogrel, ticlopidine, or even aspirin kind of drug, the action will continue even after stoppage of the drug. So usually we have to wait for minimum 1 week after stopping these drugs if we want to perform any kind of surgery. Now, one important point that you should know about these two drugs, clopidogrel and ticlopidine, are these two drugs are prodrugs. Prodrugs means they are inactive drugs. Means whenever we consume these two kind of drugs, that is clopidogrel and ticlopidine, first it will undergo metabolism to get converted into active form of the drug, and that activated drug will then block this receptor. So we have got an enzyme which is required for activation of these two types of drugs, and that enzyme is a microsomal enzyme, and that is CYP2C19. Okay, so this is the enzyme which is required for activating clopidogrel and ticlopidine. Now suppose we consume a drug and the name of that drug is omeprazole. Okay, so what this drug can do, it is an inhibitor of this enzyme. Now when this enzyme got inhibited, it cannot activate clopidogrel and ticlopidine. Okay, so that's why whenever we are prescribing to any person clopidogrel and ticlopidine, it should never be given along with omeprazole. Why? Because omeprazole will inhibit this enzyme, and when this enzyme gets inhibited, these two drugs which are a prodrug, they will cannot be get converted into active form of the drug. Okay, so this is about these two kind of drugs. Now apart from clopidogrel and ticlopidine, we have developed one more ADP inhibitor, and the name of that drug is prasugrel. Okay. Prasugrel. Prasugrel. So the mechanism of action is same. Even prasugrel is an irreversible inhibitor of this P2Y12 receptor, but it has got two difference from these above two drugs. Okay, so the difference is the clopidogrel are, I'll write with another color. Clopidogrel are slow acting drugs. These are slow acting drug, but prasugrel, it is fast acting drug. Okay, another difference is prasugrel have got a very high risk to produce hemorrhagic stroke. Prasugrel can produce hemorrhagic stroke, but no such problem is been developed by the clopidogrel, or ticlopidine. Okay, so therefore prasugrel is contraindicated in problems of stroke. Now we know that these all three drugs, clopidogrel, ticlopidine, and even prasugrel, these are irreversible inhibitor of this receptor. Because of the irreversible inhibition, their action are produced for a long period of time. Means even if we have stopped taking these three drugs, still there won't be any kind of coagulation taking place. Still the P2Y12 receptor will be inhibited. So if we want to stop this kind of problem, means immediately after stopping the drug the action should also be stopped. We want such kind of drug, so we have developed a new drug which are reversible inhibitors. Okay, so we have got reversible P2Y12 inhibitors. These three drugs, clopidogrel, ticlopidine, and prasugrel, these three drugs were irreversible P2Y12 inhibitors. So we have developed another form of drug. These are reversible P2Y12 inhibitors. And the examples are, we have got two examples for this. They are congregator and ticagrelor. Okay, we have got congregator and ticagrelor. So these two drugs are reversible P2Y12 inhibitor. So if we are consuming these two kind of drug, we are inhibiting P2Y12 receptor. And when we have once we have stopped taking these drugs, there won't be any kind of blockage of this receptor. Okay, so action will be stopped immediately. Now, as we have discussed, if we give aspirin like drug, what they will do? They will inhibit thromboxane A2. If we are giving drugs such as clopidogrel, ticlopidine, or prasugrel, what they are doing? They are blocking the activation of platelets via adenosine diphosphate. Means they are basically adenosine diphosphate inhibitors. Right? Now, if we take only aspirin, then there are chances that adenosine diphosphate can activate platelets. Or if we are taking only clopidogrel or ticlopidine, means there are chances of thromboxane A2 that they can activate the platelets, isn't it? So if suppose we are consuming a drug which is inhibiting this GP2B3A receptor, then there is no risk. By any means we cannot activate the platelets. Okay, so the drugs that are GP2B3A antagonists are drugs are apixaban, tirofiban, and aptifebatide. Okay, so these are the strongest antiplatelet drugs. And with this we have completed the antiplatelet drugs. Okay, so antiplatelet drugs, we have got three types of antiplatelet drugs. First one is thromboxane A2 inhibitor, second one is adenosine diphosphate inhibitor, and third one is GP2B3A inhibitors. And these all are the examples of these drugs.